All right. Good evening. I am Owen Tabor. I'm one of the orthopedic surgeons at Ortho South, and I am here tonight to talk about management of knee arthritis with a specific focus on partial knee replacement, which is one of the surgical options for treating knee arthritis if all else fails. This is a picture of me with a beard. Don't have one currently. I went to the University of Virginia for undergraduate and medical school, and then did my residency in Charlotte, North Carolina at the Carolinas Medical Center. Moved back to Memphis in 1999 to join my father, also Owen Tabor, in practice, and we worked together for many years, and then the practice has grown and we merged together to make Ortho South a few years ago. So basic knee anatomy, I'll go over this in a minute, but the knee has two major bones that join together, the femur and the tibia. The knee is thought of as having three compartments, four major ligaments, which are the ropes that hold the bones together. The bones are covered with articular cartilage, which is a smooth, slick cover on the ends of the bones, and there are two menisci, which are little shock absorbers in the knee. So this is a picture of a model of a knee. This is the thigh bone up here, that's the femur, and this is the tibia down here. And this stuff that covers the end of the bone, that is the articular cartilage. It's about 1/4 of an inch thick. It's beautiful pearly white in its normal state. I'll show you some pictures of that later. This little guy here, that's the medial meniscus. That's a shock absorber on the inside of your knee. That's your lateral meniscus on the outside of your knee. And then these brown things, these are the ligaments. That's a rope on the outside of the knee called your lateral collateral ligament. And your medial collateral ligament, they keep your knee stable from side to side. And then there are two little ones in the middle. This is your ACL, which if you follow sports, you hear about people tearing that. And behind it, the PCL, which is much less commonly injured. And then I've moved the kneecap out of the way just so you can see the knee joint a little better. Arthritis is a word that scares people and seems confusing, but it's really not. Arthritis is just simply the process where the cartilage on the end of the bone, that articular cartilage layer that I pointed to a minute ago, wears down over time. It can wear out because of trauma and injury. It can wear out just from wear and tear over time. And certainly some of it is genetic. If your mom or dad had knee arthritis and your big brother has knee arthritis, then you may get knee arthritis also. This is a picture of the inside of a knee. This is normal knee cartilage. This is the end of the thigh bone. These are little air bubbles here. Don't worry about those. This is a beautiful knee. That's the cartilage on the end of the thigh bone there. It's perfectly smooth and slick. This is the cartilage on the top of the shin bone, and these two parts would rub on each other when you were walking or running. And this is a normal meniscus, a little shock absorber in the knee, and that's just a perfect looking knee in a young person. This is a knee that's worn out. This is some minimal leftover cartilage here, and this here is just exposed bone on the end of the thigh bone. The cartilage layer has completely worn off. On the top of the shin bone, the cartilage layer has worn off there, and this meniscus is all beat up. These are x-rays of people with, on the left is a normal knee. That's the normal thigh bone, normal shin bone, and you see there's a nice wide space in between the bones. This is where the cartilage is. On an x-ray, the cartilage is not dense enough to block the x-ray beam, so it looks like there's a gap. And this is what a normal knee should look like, with a nice wide gap in between the bones. This here is somebody who has some moderate knee arthritis. They still have good space on the outside part of their knee, but on the inside it is narrower. And then this last x-ray here is somebody who's got bone-on-bone arthritis on the inside or medial side of their knee. They still have some good space out here, but you can see they've got no space at all left on the outside part, on the inside part. So this is the progression from normal cartilage to thinning cartilage to bone-on-bone. One of the analogies that I'll often use just to help people understand the progression of knee arthritis is I will use hair loss, for example. So you have, when you're young and healthy, you have a full head of hair, and then over time, different people, depending on their genetics, they will lose their hair at different rates, and you can have a full head of hair and start to lose hair and then be completely bald. And so this is a picture. I've got a couple of my partners here that help me out with this. This is my partner, Dr. Sines, who has probably too much hair and needs to see somebody about that. And then this is one of my partners who chooses not to be named, who is thinning a little bit. And then this perfect head here, that is mine, where you can see it has virtually no coverage at all. So that's, again, my example of a real world example of what progression of hair loss is like progression of knee arthritis. Symptoms of knee arthritis, you guys probably all know these. It's pain with walking and standing, swelling, stiffness. In advanced stages, the knee will start to get crooked. Sometimes people get to the point where they're limping. There are 4 basic stages of treatment of knee arthritis. Stage 1 is activity modification. Stage 2 is basically different kinds of pills. Stage 3 is different kinds of shots. And then stage 4 is when you get to thinking about surgical treatment options. Stage 1, activity modification. Step 1 is decrease impact activities. If you have pain in your knee only when you're jogging or when you play singles tennis or full court basketball, well, maybe it's time to give those things up. If that's not working for you, then non-impact exercise can be helpful. Biking, elliptical, swimming, things like that. And if you have a heavy-duty job that requires a lot of walking and standing, if you're a FedEx delivery guy or you're a forest ranger, you might want to see if you could change jobs and see if that can help your knee pain. Stage 2 is pills or medications. People usually start with the basic anti-inflammatory medications that you've heard of before, like Advil and Aleve, which are over-the-counter medications, Mobix, Celebrex, and there's a half a dozen other ones that are prescription medications. And different medications work differently for different people. So just because Aleve works for your buddy doesn't mean that that's going to work for you. And most people will try 2 or 3 different ones and see if they can find one that will work. And when I say work, I mean that makes your knee hurt less, and so you can go about your life without interruption. Some people use those medications every day, which is fine, and then some people will just use them occasionally when their knees bother them. There are other pain relievers you can take, like Tylenol, Ultram, things like that. Narcotics are not a good long-term option for knee arthritis. As everybody knows, they're addictive, they're habit-forming, they wear off over time to the point that you have to take more medication to get the same effect, with a lot of side effects. So if you're at the point where you're thinking about taking a narcotic for knee arthritis, you need to switch and try something else. There are supplements that are not proven, but they do seem to help a lot of people. Glucosamine and chondroitin sulfate, which is sold as Cosamine DS or Osteobiflex. There are a lot of different concoctions of that you can get in any of your local drugstores, Walgreens or whatever. And then some people don't like taking pills and they want to try to stay as natural as possible. And one solution for that is turmeric, which is a powder that you can pick up at a Whole Foods, or a lot of the specialty stores like GNC's and places like that will sell turmeric. And that's a natural anti-inflammatory. If pills aren't working and activity modification hasn't worked for you, then the next step is to try injections or shots. Cortisone is a generic term for steroids. There are a lot of different kinds of steroids that you can inject in the knee. Each doctor usually has their preference, but frankly, they're all about the same. Steroid or cortisone injections are really helpful for knee arthritis, especially the first time you get one. It's amazing. Sometimes people will come and they've been hurting for months, limping, their knee's swollen, and they're miserable, and you drain their knee and put a cortisone shot in there, and they feel great for weeks and sometimes months. You can repeat those injections every few months as needed. There's not a law about how often you can do it, but most doctors won't do those more often than every 3 months or so. If you are diabetic, then the steroid injections can make your blood sugar go up for 24 to 48 hours, and you need to know that so you can keep a good eye on that. If the steroid or cortisone injections are not working, they're not lasting, or if they give you significant side effects like blood sugar issues, then the next step is what's called viscosupplementation. There are a lot of brands for this. People call them gel shots or rooster comb shots. I think they're kind of like peanut butters. The different brands all work about the same. Some people like Synvisc or Supartz or Monovisc or Hyalgan, and your doctor will probably have 2 or 3 of those options on there available. Frankly, a lot of the insurance companies will contract with one particular company, so I saw somebody recently, and they have United Healthcare, and if you're on United, you have to use Uflexa, and they all work fine, so I wouldn't get too hung up on which brand it is. And they are pretty helpful in a lot of people. Insurance will usually cover those about every 6 months. If the steroid shots and the gel shots aren't working, there are nerve blocks for the knee. It's called a genicular nerve block, and they can give you good relief for several months. None of these options that I'm talking about are permanent. They're basically to buy you some time. If you've tried all those other options and your knee's still bothering you and affecting your quality of life, there are a couple of surgical options. Arthroscopy, which is also known as a scope, that can rarely be useful in somebody who's got advanced knee arthritis, just to clean the knee out. It sometimes helps, but it's also usually temporary. There will be situations where your doctor may tell you that they think that a knee arthroscopy is a good idea if you've got knee arthritis, but most of the time it's not really going to help you. And then the last option is joint replacement. Joint replacement is where you resurface the ends of the worn out bones. One example I will use is the picture here is a road. Okay, if you get a newly paved road and it's perfectly smooth, then you can drive your car along it with a full cup of coffee or a full glass of water and it won't spill. But over time, that road starts to get some cracks in it and some potholes and some debris on it, and the road gets rougher. And at the end of the line, if the road is just not functional for you anymore, then the city comes over and they tear off the top layer of the road and they repave it, and then you've got a new road. Well, that's kind of the idea of a knee replacement, is you take off the worn out end of the bone and you resurface it with metal and plastic. Resoling a shoe is another analogy that I'll use sometimes. If your sole of your shoe is worn out, then you can take it to your local shoe repair place and they can put a new sole on there and you're good to go. How do you know that it's time to replace your knee? Well, if your pain is limiting your daily activities, if it's affecting your sleep, if your bad days outnumber your good days, definitely if you're needing narcotics to manage your pain, it's time to move ahead with a knee replacement. And then a lot of times, if the person with the knee problem can't decide, their wife or husband or children will tell them, hey, look, you're barely walking and you're not going to church and you're not coming to the grandkids' baseball games anymore. Get your knee fixed and get your life back. So what do you need to know about knee replacement if you're going to have a knee replacement? Does it work? Yes, it does. 95% of people who have a knee replacement are glad they did it. It is not the knee that God gave you, but it's a lot better than the one you came in on. The first month after a knee replacement can be pretty rough. A lot of people in that first month will think maybe they shouldn't have done it. But once they get through that, things get better every month. Total recovery is about 12 to 18 months. That means that you're going to continue to improve for up to 12 to 18 months. Generally speaking, in that first month, people are having a hard time getting around much. They're on a walker for a couple of weeks, sometimes 3 weeks. Knees pretty sore and pretty swollen. Then the second month is better, and the third month is better, and every month gets better after that. But again, most people, it takes them 12 to 18 months before they're fully recovered from their knee replacement. Now, as far as going back to work, it depends on your job. There are people who go back to work 10 days after surgery because they've got mainly a sit-down type job. If you've got a heavy labor job, it can be longer than that, and sometimes 3 months if you've really got to do a lot of walking. And for some occupations like police and firefighters, I'll tell those folks to stay off up to 6 months. Knee replacements last a long time. In general, the failure rate is thought to be about 1% per year. Recent data has suggested that maybe the numbers are even better than this, but in general, for round numbers, you can expect 90% of knee replacements to last 10 years, 80% to last 20 years, and that trend seems to continue into the future, though we don't really have much information about after 30 years. There's just not a lot of people who've had a knee replacement in place for 30 years to track that. So another way of thinking that is if you and 99 of your best friends all get a knee replacement in the same year, each year one of you will probably have to have something done about your knee, maybe another operation or some other type of treatment for it. So 20 years down the road, if you guys all get together, then 80 of you are still going to have your knee in place and working, and 20 of you will have had to have another surgery, maybe had to have the knee redone at that point. There are two basic kinds of knee replacements. The most common kind is a total knee arthroplasty. That's where the entire knee is resurfaced. And a less common but less invasive and easier to recover from knee replacement is called a unicompartmental or partial knee replacement. In a total knee replacement, all three of the compartments in the knee, the inside, the medial side, the lateral side, and then the part where the kneecap slides, all three of those compartments are resurfaced. Both of the menisci, both of those shock absorbers are removed, and the two big ligaments in the middle of the knee, the ACL and usually the PCL, are also removed. In a partial knee replacement, only the damaged compartment is resurfaced. So you have three compartments in your knee. A partial knee replacement is appropriate for somebody who has damage only in one compartment and the other two are in pretty good shape. So only the damaged compartment is resurfaced and the remainder of the knee is left intact, meaning all ligaments are left intact. The meniscus on the opposite side of the knee is left intact. Who is a partial knee replacement candidate? Again, the arthritis has to be isolated to just one side of the knee. Usually it's the inside or medial side of the knee. Every once in a while it'll be on the lateral side of the knee, and even more rarely it'll be the compartment where the kneecap slides, called the patellofemoral compartment. The knee needs to be stable. If your knee is unstable and given out all the time, the partial knee is probably not the right operation for you. You need to have pretty much full motion in the knee. If you can't straighten your knee all the way out, or at least most of the way out, and you can't bend it past 90 degrees, a partial knee replacement is probably not going to be a big enough surgery to correct your problem. And partial knee replacements don't work typically well in people who have inflammatory arthritis. That would be rheumatoid arthritis, lupus. Usually don't work well in gout. So if you've got that kind of arthritis, again, you'd probably need a total knee. And these are the reasons that most people, probably 2/3 of people who have knee arthritis, total knee replacement really is the only reasonable option for them. These are x-rays of somebody before and after a partial knee replacement. This x-ray here shows somebody who's got no cartilage at all left on the inside or medial side of their knee. They've got good space or good cartilage left on the outside part of their knee. And then this x-ray here shows a knee after a partial knee replacement. The white is a metal cap that goes over the inside knob of the thigh bone. This is a metal plate that goes over the top of the shin bone, and then in between is a plastic spacer that doesn't block the x-ray beam, so it looks like there's nothing there, but there's really a plastic spacer in there. This is an x-ray of a total knee replacement where you can see both sides of the knee are resurfaced with a larger metal implant. Both sides of the shin bone are covered with a larger metal implant. This is a side view of the knee. The underside of the kneecap is also resurfaced with a button here. The advantages to a partial or unicompartmental knee replacement are it is certainly less invasive. The incision is smaller, there's less muscle damage, the surgery doesn't take as long, much less bone is removed, all of the native ligaments are left intact. And again, as I mentioned, in a total knee, you remove the ACL always and the PCL most of the time. The other advantage to a partial or unicompartmental knee replacement is most people can do that as an outpatient. It's pretty unusual for somebody to have to spend the night after a partial knee replacement, so they can come in and go home the same day, which is possible with a total knee replacement, but much less common. The risk of complications is lower. The risk of infection, which in a total knee replacement is about 1%, is virtually unheard of in a partial knee replacement. It's also virtually unheard of for a partial knee replacement to lose enough blood to require a transfusion. Stiffness almost never occurs. Both of those things are potential complications with total knee replacements. Most patients that I do a partial knee replacement on don't end up needing formal physical therapy. They're up and moving well enough that they can get on a stationary bike on their own, get back to exercising on their own, and don't have to go to formal therapy. Some people do, but most people don't. And if push comes to shove and the knee doesn't work out, if a partial knee replacement has to be revised, it is much easier to revise to another partial or to a total knee replacement if necessary. A revision of a failed total knee replacement it's a big deal with significant complications, very hard on the patient, and certainly something you'd like to avoid if at all possible. There are disadvantages to everything, and there are disadvantages to partial knee replacements. The main one is that the failure rate in the first 12 months for a partial knee replacement is higher than it is for a total knee replacement. In general, if you do 100 partial knee replacements, 4 of them will have to be revised for some reason or another in the first year. versus about 2% for a total knee replacement. So 4% isn't a lot and 2% isn't a lot, but it is more for a partial than a total knee replacement. And theoretically, the other parts of the knee that are not resurfaced can wear out over time. I've been doing this for over 20 years. I've seen a handful of instances where the non-resurfaced part of the knee wore out, but most of the time it doesn't, which is a little surprising, but they hold up really well for a long period of time. This is a model of a partial knee replacement, where again we saw this earlier, where you've got the thigh bone up here, and in a partial knee replacement, all this normal cartilage is left. This is the groove where the kneecap slides; it's left alone. The outside half of the shin bone is left alone, and this little implant is placed right here to cover the worn out part. So this is a much smaller implant, as you'll see, compared to a total knee. This is a model of a total knee replacement, a much larger implant going over the end of the thigh bone. This would be, in real life, it'd be a metal and plastic composite implant that goes over the top of the shin bone. If you just look at these are actual implants. This is a partial knee replacement here with the thigh bone piece and the shin bone piece lying side by side against a total knee replacement, which is 4 times larger than a partial knee replacement. And this is reflective of the amount of bone that you have to remove to get this implant in. If you think about it, the implant is replacing removed bone. So in a partial knee replacement, you remove this much bone. In a total knee replacement, you remove this much bone. So how do you know if you're a partial knee candidate? Again, we talked about this a little bit earlier, but you hurt mainly with activity, not much at rest. People that have a lot of pain at night and when they're just sitting around, a lot of times that's an indicator that there's more going on in the knee than just some basic wear and tear. And those folks are often better treated with a total knee replacement. If the pain is mainly on one side of the knee, either the inside or the outside or in the kneecap, if it's all over if your whole knee hurts all the time, that probably means that your whole knee is damaged and you probably need a total knee replacement. Again, your knee needs to move pretty well. It needs to be stable and not having a history of rheumatoid arthritis, lupus, or gout. So I'm here for questions. If anybody's got any, I'm happy to answer them. Thank you.
All right. Thank you so much, Dr. Tabor, for that presentation. And we do have some questions that we've already collected ahead of the webinar. If anyone has any questions that they would like to type into the group chat, feel free to type those away and add. Starting now, and I also want to give you an opportunity, Dr. Tabor, to turn on your camera if you have not already. There he is.
Hey.
All right. So our first question is a little long, and it's kind of specific. It came to us this past Monday, but it basically boils down to walking less. So it says, a few years ago, I hurt my back and I have some sciatica in my left lower back, and a few of my left toes are numb. They call it floppy foot. So I walk a lot less than I used to, and I have to pay attention so I don't lose my balance to the left. I'm afraid I'm hurting my knee by walking with my toes pointed outward, which is what I use to help me keep my balance. But I'm worried about long-term issues with my knees. Are there any suggestions that you have for that?
Yeah, it sounds like you have what's called a drop foot from the nerve problem in your back. If you have not seen somebody about that, an orthopedic doctor or a neurosurgeon, it may be correctable, probably not, but it may be correctable, and certainly you'd like to try that. There's a very simple brace called an AFO, stands for ankle foot orthosis, and it's a little plastic brace. It'll slip inside your shoe, and it will keep your foot from dropping when you walk, and then you won't have to walk with your foot turned out to the side, and that can be tremendously helpful. You have to have a prescription for it. You probably can get it from your primary care doctor. If not, you can see any orthopedist or neurologist or neurosurgeon, and you would really benefit from getting an AFO. Now, is it damaging your knee walking with your foot out to the side? I can't answer that specifically. I mean, obviously your body was designed to walk a certain way, and that is with your foot forward, but you can't do that. So your best bet is to get to where you should be able to walk more normally if you get an AFO. So I hope that helps. Thanks.
Thank you. Our next question is, how long is the normal recovery time post-surgery?
So recovery is a hard question to answer. So this is how I answer this typically. And it's a little shorter. As I said, it's a little shorter for a partial knee than a total knee. And there are a lot of other patient-related factors that go into recovery. But in general, if you take all comers, for a total knee replacement, people are on the average in the hospital for 2 nights. Some people 1 night, some people a little longer. Some people can do that as an outpatient, but that's not that many people. Typically, people would be on a walker for 2 to 3 weeks. And again, that really is dependent on how your balance is and how adventurous you are. If your balance is pretty good and you're somebody who kind of wants to move along quickly, people are sometimes off their walker in a week to 10 days. If your balance isn't very good, because maybe like the previous question, you've got some back problems and you got a foot drop and you've got some other issues, you may be on the walker longer. As far as usually by a month after surgery, people are doing as well or better than they were before surgery. And then it gets better every month, like I talked about in the webinar there, it gets better every month. People improve for 12 to 18 months. People are usually back to their normal life by 2 to 3 months, but their knee's still kind of swollen and hurt some, and they're having some stiffness. So the first month is rough. People are usually back to their normal life in 2 months, and then their knee is fully recovered at 12 to 18 months. Those numbers are all shorter for partial knee replacement. Most partial knee replacement patients have the surgery and go home the same day. They're typically off a walker in a week, maybe switch to a cane by a week. And the recovery is faster just because it's a smaller surgery, it's less invasive, there's less bone removed, and it's easier to recover from. Hope that answers your question.
Does Medicare cover the cost of the procedure?
Yes, Medicare, if you have only Medicare with no supplemental insurance, then Medicare covers about 80% of the cost. Most people have Medicare, and then they have a supplemental insurance which covers the rest of it. So most patients that I see on Medicare you do have a small deductible with Medicare that I'm sure you're aware of, but other than that, it's completely covered.
Great. Next question is, does obesity affect eligibility for surgery?
It does. Most people will not, most doctors will not do knee replacements on people with a body mass index over 45. Body mass index, also known as BMI, that is a ratio of your height to your weight. And there's a simple app on your phone that can tell you, but a body mass index of over 45 is pretty big. So I'll just pull that up. For example, if you are, let's say you're 5'8". You'd have to be 300 pounds or more to have a BMI of 45. And so if you're taller, then you could weigh more. And if you're shorter, you can weigh less. And the reason that people don't do knee replacements in general, there are exceptions, but most of the time they won't do a knee replacement on people with a BMI over 45. And there are some doctors that won't do it with a BMI over 40, but most people it's 45. There's a lot of research that shows that the complication rate for the surgery goes up to an unacceptable level when you have the patient with a BMI of over 45. The infection risk, the blood clot risk, all of the problems that are inherent in knee replacement are much more common in people with a BMI of over 45. And the knees don't last as long, and it's just that's something. If your BMI is over 45 and you need a knee replacement, if you can't lose weight on your own, that is a great reason to consider surgery for weight loss, which is called bariatric surgery. So, I think some people feel like doctors are being mean because they don't want to do the knee replacements on people with a BMI that's super high. But the problem is it's not the right thing to do with a correctable problem like weight loss. So I hope that answers your question.
Thank you. This next question is, how long is the rehab period post partial knee replacement?
Most people with a partial knee replacement don't have to go to physical therapy. The purpose of physical therapy, mainly after a total knee replacement, is because the knee can get stiff if you don't have a supervised therapy program. And partial knee replacements they just don't get stiff. There's not as much soft tissue dissection. The surgery's not as big. It's just, I've done getting close to 1,000 partial knee replacements. I've had maybe 1 or 2 get stiff, and those are super unusual. About 10% of people who have a partial knee replacement are just struggling to get off their walker after 3 or 4 weeks, and I'll send them to physical therapy. But most of them, they don't have to do anything if they don't want to. If they have access to something like a stationary bike or an elliptical, that's a great way to get their knee moving and get their strength back. So I do ask people to restrict their what I call recreational walking for about 6 weeks after a partial knee replacement, because there is a risk of getting a stress fracture. I mean, the problem is that people recover so well from it that sometimes people are coming in at 2 and 3 weeks and they feel good and they want to go walk their dog or go play golf or go turkey hunting or go shopping for 3 hours. And you got to give your bones a little bit more time to recover than that. So they feel too good and then they get in trouble.
That's definitely something to think about. The next question is, how much exercise is safe for a healthy 60-year-old with mild arthritis in one knee? For instance, is running 1 mile a day in addition to walking okay?
It's okay. I mean, running's great exercise, but it's just the impact on it's hard on a knee that is not normal. So, there are people, I mean, the runners love running. So if you love running and you're willing to put up with it, you can go for it. You'll do better on a softer surface. Like running on the grass or on trails. The folks that I have who have some knee arthritis and they love running, I encourage them to run faster for a shorter period of time, maybe interval type running where you're running pretty hard for a minute or so and then you walk until you catch your breath. It's the long, slow, 5-mile plod at 12 minutes a mile. That's brutal on your joints and your knees. So I would recommend probably anything other than running for exercise, but if you just can't help it, then run hard for shorter periods of time and not the long, slow plod. I run a little bit and because it is a great, efficient way to exercise. But I'll typically run for a few minutes and then I'll walk for a while. I'm getting old.
Next question is, how effective are gel injections for knee pain?
It's a great question. So we studied that. I had a medical student one day who needed a research project. This has been a couple of years ago. So we got him to look through a couple of years worth of gel injections done by everybody in our group. And it was a big study and it showed what I expected it to show, which is about 60% of people who get gel shots are glad they did it. And that means that they got at least 6 months of significant pain relief where they thought it worked well enough that when the shots eventually wear off, which they do, but they got at least 6 months of relief. And when they came back after that period of time, they wanted to do it again to put off a knee replacement even further. 40% of people who get the gel shots, it just doesn't help. And nobody has been able to figure out, nor have I, what the demographics are where it helps and doesn't. It doesn't seem to be right knee versus left knee, or male or female, or young or old, or terrible x-rays or not so bad x-rays, or tall or short, or Chevy driver or Ford driver. It's hard to tell, but about 60% of people, it is a good way to put off a knee replacement with virtually no side effects. So I use them a lot. If people are hurting and the cortisone shots are not lasting and the pills aren't helping and they're just not ready for surgery, gel shots are a great idea, but it might not work.
Thank you. The next question is, do you offer new surface meniscus replacement surgery?
That I'm actually on the review board of the new surface implant, so I have not been able to use it because it was a conflict of interest to review it and use it. It is waiting for FDA approval. It is still in that process, and if it is approved, which I think there's a good chance it will be. I don't have a crystal ball, but when it will be approved, and there are people I will use that for. I think it's a good idea. It's not perfect, and it's got a pretty limited scope. It's for people who have, it's really for somebody who's had their meniscus removed because of meniscus damage, and they have a lot of pain, but they don't have a lot of arthritis. So it's really kind of too early to think about a replacement, but because they still got a pretty good knee, but they're just hurting all the time. So I definitely see using it if it's approved by the FDA, and hopefully it will be.
Excellent. The next question is, if a person has had an ACL replacement, are they a candidate for partial knee replacement?
Yes, definitely if their ACL replacement or ACL reconstruction, if it worked. I mean, if their knee is stable and their replaced ACL is still functioning, then that is absolutely fine to do a partial knee replacement in them. If your ACL is not functioning, if you have a torn ACL or you had it replaced and then it retore, the correct answer on the orthopedic board test is that you should not do an ACL on those patients. I will say that depending on how stable the knee is, I have definitely done successful partial knee replacements on people who do not have an ACL. But if the knee's really loose and really unstable, then you have to do a total knee, because that's a more constrained type implant. But so it's really, if your ACL has been replaced and is functioning, then absolutely partial knee replacement is reasonable. If your ACL is not functioning, then it's a maybe.
Great. By the way, everyone, just thank you so much. These are some really great questions that are eliciting a lot of really good information. The next question is, do you use the conformist prosthesis?
I have not used the conformist. Won't really go into it. I use Smith & Nephew implants. I have forever. I don't have any kind of financial relationship with them, but they make great stuff. They're local. You never have to worry that you're in the middle of a surgery and need a size 6 left knee, and we don't have one, because the manufacturing plant's right down the street. So nothing against the conformist, but most people that do knee replacements will use one system and stick with it. The analogy I use for that is they're kind of like cars. Okay, there are lots of good cars, but if you're going to go on a road trip and you are going to need to possibly change your tire and put on your hazards and play the radio stations and change your oil, and if you're going to have to do a lot of different stuff, and a knee replacement has a lot of steps and there are a lot of things that have to be tweaked. You don't want to be in an unfamiliar car, and you don't want to be using an unfamiliar knee system. I remember I rented a car one time. I was out of town, and it was a Volvo, and I couldn't figure out how to open the gas tank. I had to, thank goodness for YouTube. I know how to open my gas tank in the car that I drive every day. But so generally speaking, if you're going to have a knee replacement by any doctor, I wouldn't worry about the implant they're using. The knee implants are so similar. If Smith & Nephew went out of business tomorrow, I would switch to a different implant. I'd have to learn their system, which would take me a little while to do that. But long answer to a short question, I do not use the conformist implant. I think there are a couple people in town who do, but I don't.
Thank you. We just have a couple more questions now. Someone asks, is there a lot of pain with a nerve block?
No, really. I mean, the nerve. Well, there are two kind of nerve blocks. There's the kind that I mentioned in the talk, which is called a genicular nerve block, and that is to limit the pain in your knee. And that is no. I mean, so you can go have a little bit of sedation if you're really anxious about needles, and then you won't even know you had it. But it's just a shot in the knee. I don't do them. I have partners that do them. It's a procedure that I just hadn't done before. But I rarely have had anybody say, wow, that hurt. So, and then there's another nerve block that people have before surgery to numb up their leg for a few hours, and that doesn't really hurt either. So knee replacement hurts. I'm not going to kid you. That hurts, but a nerve block does not. So don't not have a nerve block because you're worried it's going to hurt.
Thank you. And unless anyone else has more questions to ask, this is going to be our final one, but please feel free to add anything else if you do have any additional questions. This last question is anesthesia the same for the uni and total knee replacement?
Pretty much, yeah. It is shorter. And most people, the anesthesia for knee replacement is either general anesthesia where you go to sleep, or spinal anesthesia where you're numbed up from the waist down. And that really doesn't, that's not surgery specific. That's really what the patient wants and what the anesthesiologist wants. And sometimes that depends on your health. It's really 50-50. People argue about it, but most people acknowledge that it doesn't really make any difference as far as outcomes. And most people get nerve blocks before partial or total knee replacement because they work great. A lot of people don't have any pain at all for the first 12 to 18 hours, which used to be before nerve blocks. It was a pretty miserable time period after a knee replacement. So that's been a great advance and part of the reason that we can do these outpatient. And so the anesthesia is about the same.
Excellent, thank you. I did get another question. What do you think about stem cell injections for knee arthritis?
That's also a great question. I don't think anybody really knows the answer to that. Stem cells, I've had patients who, I don't do stem cell injections, but I've got partners that do that. I'm not against them or for them. I've had patients who've had stem cell injections that thought they were great. And I've had patients that had stem cell injections that felt completely ripped off. And they are expensive and they're not covered by insurance. There are people around town and around the country who will try to charge you $5,000 or $6,000 for stem cell injections for each knee or more. If you're thinking about stem cell injections, I would shop around because they're not regulated and people charge all kinds of different amounts for them. I think it's a reasonable option if you need a knee replacement and you have tried everything else and you're willing to spend some of your hard-earned money on something that might or might not work. And for a lot of people, that's a reasonable thing to do. And there are also people who, for health reasons, they just cannot have a knee replacement. It is not an option and they're miserable. And for those people, I would say that is a good idea. But beware, I think at best it's a 50-50 chance that it's going to give you some relief. It is not going to give you your 18-year-old knee back. It is pretty much unlikely to solve your problem. It may help you by a year or two or three. If they worked in everybody, that's all I would do. Life would be much easier just to do stem cell injections and not do knee replacements. But it's a reasonable thing to try. But again, it's not covered by insurance and it's expensive.
Fantastic. Thank you so much. And on a point of personal note, I wonder if you can speak to our surgery centers and the same day joint replacement that is offered in our surgery centers right now for, I think it's for knee and hip. Of course, knee is the one that is covered by Medicare, but I wonder if you can just explain that process versus the inpatient process.
Yeah, that's becoming much more popular. Outpatient knee replacement was a pipe dream 10 years ago, but a lot more people are moving to that. The anesthesia has gotten better so that people are waking up easier. The surgeries are a little shorter than they used to be. And more people are choosing to just go home, and it's working out well for people. I tell people that when I'm talking to them about outpatient surgery, they have to be pretty mobile. I had a guy today, and he's got 2 terrible knees. He's not going to be able to do his surgery as an outpatient because he can barely walk on either of his knees. So he's going to need to be on a walker, and it's going to take him a while to get up and get moving. So you've got to be pretty mobile. You've got to have good health. You don't want to have an outpatient knee replacement if you've got heart disease and diabetes and lung problems, because you want to be monitored in the hospital for a couple of days if that's happening. But if you're in relatively good health and you're relatively mobile, except for your one bad knee or one bad hip, and you've got good help at home, you don't have to have a nurse at home, but you need somebody staying with you for the first couple of nights, somebody that maybe can help you up if you need a little help getting out of your chair, maybe can bring you your pain medicines if you need them. But people are doing really well with it. And I think you're going to see a lot more people choosing to do surgery as an outpatient because they just don't want to spend the night in the hospital. And it's less expensive to do it as an outpatient. It's just a better experience. But it's not for everybody.
Dr. Tabor, thank you so much for your time tonight. Everyone who stuck with us, thank you for attending. If you have any questions at all, feel free to email us, call us at 901-641-3000 at any time. We're always here to answer your questions.